All right, welcome to this conference. Those of you who've been with us before would know the format of the presentation. Those who are new, we try to do this once a month, and the Diagnexia Digital Laboratory is the platform that I use, and they advertise it and help me present as well. So if you have anybody who wants to join this conference, then the idea would be to get onto that list, and you could email me and I could forward it to Ava, who's helping me with this presentation, who's hosting it and helping me. Otherwise, I think we can start off where we left off, and the format is I will give you a history, show you the H&E slides, and then you can put in your differentials and questions and comments in the chat, and I will try and answer them as best as I can as we go along. Okay, sounds like a plan. I hope you can all hear me. This is just continuing where we left off, and yeah, this we received as a consult. It's a 46-year-old woman, which came in as a fibroid. And you can see the sections of the fibroid that were received on low power. And then just on high power, I'm going to take you through the myometrium just to give you a sense of normal myometrium. And then the tumor itself, which is fairly well demarcated, but this is the tumor. And before I ask what you think, I'll show you a few features. And you can see that multinucleated cell there. And I'm just showing you a high power of these cells, which some of look a little epithelioid as well. And in other areas, they're more spindled. I guess that epithelioid looking areas could be the spindle cells cut across as well. But there is another feature I want to show you, if I can find it. It's been a while since I looked at this slide, but here, this is a focal area. You can see a focal area here, just on low power, fairly well circumscribed. And looking at the tumor, this particular area, just to give you a feel for what you think of these cells as well. All right, any thoughts? And you can just place it on the chat and I'll respond and we can talk about it. Anybody have any thoughts? And came in as a fibroid, has these spindle cells and these areas which show atypia. I've shown you some areas that have high power. Okay, I've got adenomatoid tumor. And I'm just going back to the top. There's somebody who has an AI assistant helping. Interesting. And here, there's a fumarate hydratase deficient leiomyoma, which we abbreviate as FH deficiency. And then there's adenomatoid tumor, and then basal leiomyoma. Let's start with the adenomatoid tumor. That's a good thought. These do occur in the uterus, uteri. They typically occur around the junction between the fallopian tube and the isthmus area. So those are usually well circumscribed, and you can see them on gross as well. They have cords and nests and sometimes even glandular structures. There's another suggestion here. And then, of course, the adenomatoid tumor, if you really want to investigate that, you can always use the mesothelial markers, and because adenomatoid tumors are made up of mesothelial cells. They're entirely benign, well circumscribed, but just to mention that you can get mesotheliomas that look like adenomatoid, and it's called adenomatoid-like mesotheliomas. I don't want to go on that tangent. This marks up as smooth muscle, and I should mention that there are leiomyoma of giant cells, symplastic leiomyoma, and basal leiomyoma. I believe the current WHO uses bizarre leiomyoma, I think, but please, you can check that out. There's also an atypical leiomyoma I see in the chat as well. There's also endometrial stromal nodule, which are usually well circumscribed. Remember, they can go up to probably 10, 15, 20 centimeters, very well circumscribed. Those are usually made up of endometrial stromal-like cells, which is very dark, small cells and very blue. This has an abundance of pink cytoplasm, as I showed you earlier on, and so does the bizarre looking cells here as well. There's about 3, 4, 5 people who've hit the nail on their head. This is an FH deficient leiomyoma, and the way to prove it is to use the antibody to FH, fumarate hydratase, and it would be deficient. It would be lost in the nuclei. So there are some features here which would help you think about that. And one of the features is that you can get this bizarre appearing cells in fumarate hydratase deficient leiomyoma. So whenever I see this, I always do and order the FH antibody. The other feature here, which you will read in the textbooks, is the so-called alveolar edema. And you can see this area of alveolar edema, which I didn't get to show you on low power, but there's nice alveolar edema. One of the other features that I did see were the prominent nucleoli when I went down on high power, just to show you some of that. And sometimes you can get a little halo around those nucleoli. And that was published in Modern Pathology in the early teens. By that, I mean 2012, 2013 from MSK. The other feature, which some of you may have spotted, are these eosinophilic globules. And oh, there's a nice one here. These eosinophilic cytoplasmic globules. So those are also useful, helpful diagnostic feature. None of these are specific for FH deficient leiomyoma, but the sum of all of them do make you think of that. And if you have the antibody, then it's much easier. You can always use the antibody. Remember that FH deficient leiomyomas can be sporadic or inherited, and the absence of FH does not necessarily make it inherited. So they are autosomal dominant. I think we talked about this the last conference, but you're all familiar with the hereditary leiomyomatosis syndrome. And if you're picking that up, then these patients have to undergo genetic counseling, largely because of the renal cell carcinomas, which are highly aggressive, and you would help those to be picked up early. They also have cutaneous leiomyomas as well. Okay, any questions or comments on that? I'm just checking down here. There's a leiomyosarcoma. You can get an FH deficient leiomyosarcoma, and you would use the same criteria that you would use for leiomyosarcoma mitoses. The atypia, of course, has to be diffuse. Here it's very focal. And then, of course, the necrosis is also useful. Picoma is a good thought. Some of them do look epithelioid and should be entertained. My general thinking these last few years, when I look at any peculiar uterine tumor, I always ask myself, is this a picoma? Or is it an IMT, inflammatory myofibroblastic tumor? Or is it utrost? That's uterine tumor resembling ovarian sex cord-like tumors. So that's my general approach. Anything that looks funny in the uterus, that's not a fibroid or leiomyoma and not an endometrial stromal tumor, I always ask myself. So if you're asking yourself, is it picoma, you're going to do the myomelanocytic markers. HMB is a good screening tool, MELAN-A as well, and then of course SMA and the muscle markers, which you're all familiar with, SMA, Desmond. Even HCAL Desmond can be diffusely positive in them. Another marker that we have is cathepsin K, which is also useful, not specific, but useful in the panel for picoma. Utrost, you all know, typically has a heterogeneous morphology with nests and cords and sheets, spindled, epithelioid. They can look pretty different, and very rarely do you see two utrost that look similar. And the way to get around that is that they do show mesenchymal markers, epithelial markers, and endometrial sex cord stromal markers. So those are my go-to would be SF1 and inhibin for the sex cord stromal, keratins for the epithelial markers, and then of course your the other panel can help with that as well. Mesenchymal markers like muscle and the ones that we've already mentioned. And then IMT, interestingly, the IMTs of the uterus tend to show more ALK rearrangement and ALK staining than any other IMTs in the body. So if you do GYN, then you're lucky to just have that one antibody to help you with IMT, inflammatory myofibroblastic tumor. Okay. Is CD56 a better marker than it? I don't trust CD56, Shaheen. CD56, I mean, CD10 I would use in the context of endometrial stromal tumors. I know in the old days, some people use that for the mesonephric-like cervical adenocarcinomas, but CD56, no, I don't. And a lot of people, it's mentioned in the books, and I think it's just to fill the paragraph with the antibodies, and it's used in a wide variety of things. And it's even used for neuroendocrine markers. And if you have CD56, give up the 56 and get an INSM1 to complement synaptophysin and chromogranin. I don't even use 56 for neuroendocrine markers. So 56 for me does not, play much of a role, and I don't use it that much. That's a good question. That's a good question. So inhibin, as you know, also stains adrenal cortical tumors. So bear that in mind as well. But if you can get SF1, steroidogenic factor 1, that's very useful as well. Again, none of these markers are specific. There is no marker that's specific. Our late great Dr. Levolsi used to say that thyroglobulin was specific. But bear in mind that when you are tackling a tumor that you want to characterize by immunohistochemistry, I always use a minimum of 2 antibodies per antigen. And so, like I said, if I'm concerned about neuroendocrine, I'm using all 3. Because the consequences of the patients are critical in terms of whether it's well differentiated or poorly differentiated, and the treatment also depends on that. So, nope, I don't use CD56 at all. It's not even a go-to for me. Even Vimentin, I don't use Vimentin at all. Some people do propose Vimentin to be a good test of the immunogenicity of your system. That's a good way to check it out. Is if the Vimentin is positive in everything. I mean, mesenchymal, epithelial, melanocytic, stromal, etc., then you know your system is working. That's probably the only time, and that I would, and that's very rare that our system is questioned. If your tissue is well fixed and processed in your laboratory, then your antibodies are optimized for your laboratory fixation and processing, and they should work well. Okay, good questions, and I appreciate the questions. It's always good to talk about these aspects that affect our daily sign out. Okay, I will move to another case. 43093. Let's try this one. Okay, I'm just trying to organize myself here so I can see your chat. It makes for easier viewing for me. So this is a above knee amputation. So that gives you some clues as well. This is a woman. She's 63 years old, and she had an AKA, above knee amputation, with a right proximal tibia mass. And I don't have the radiology, but the radiology was aggressive. So I'll give you that. Okay, I was just looking at the chat, distracted by the chat, so that you can get a sense of it. But generally, when I'm talking to trainees in our department, I typically put up a slide with a bone tumor and then ask for any suggestions and wait for somebody to say, can we have the X-ray? The radiology is critical for bone tumors, never underestimated. if it's a consult and you cannot get your hands on the radiology for your own friendly radiologist to read, then at least get the report. That's helpful as well. Now on low power, you can see that this does have two components here, and I'm going to take you through both components. So here on the left, you can see these nice well-formed lobules. Okay, and I'm going to show you these lobules before we talk about it. All right. Yeah, just a high power to give you a sense. Two fields, one a little more cellular than the other. Okay. Yeah, there is a suggestion lobules of cartilage and spindling. I've got chondrosarcoma there as well. That's excellent. There are a few features here I want to show you. Uh, I did say that this was destructive and aggressive on radiology, which is a useful clue for cartilaginous tumors. And I've already got a suggestion here of chondrosarcoma, and then a good observation is the bony permeation present. And that's what I wanted to highlight here as well, because you can see these lobules of cartilage invading the trabecular bone. This trabecular bone is the resident bone, and you can see that the tumor is invading the bone. Now, how do I know that? Is because you've got cartilage on both sides of this trabecular bone, and that's known as entrapment. So you've got the entrapment of the bone, and that's a feature of permeation, as opposed to benign enchondromas, which is encasement, and you can get bone around the periphery, not too infrequently in a chondroma. There's a suggestion here of a lobular carcinoma, and then presence of ring and arc type calcification in radiology. Okay, so there's some radiological features which are helpful for you to look at. For the lobular carcinoma, remember, you can get keratin in cartilage as well, so be careful of that. S100 is also positive in cartilage. So if you get a needle core biopsy, remember your radiology is going to be useful, and radiologists can pick up cartilage quite nicely with CT and MRI. They have techniques and tools to do that, and I would trust my radiologist when he says or she says this is cartilage, and that's helpful as well. She did not have a history of breast cancer as well, just to get that out of the way. Here you can see again these lobules of cartilage. You can see these chondrocytes, some of them having lacunae here as well. And what grade would you put this under? I see some people have also given periosteal osteosarcoma. So the periosteal osteosarcoma again has to be on the surface, and they typically do have a cartilaginous differentiation. This is intraosseous. I should have told you that. I did not show you radiology in order to intramedullary intraosseous in order to expound those features. Now, the second feature here is I want to show you these dark areas, and I want to show you the abrupt transition from these lobules of cartilage. Somebody did say they look spindled. And here you can see the second component. I can see that's being asked. I can see that there's some grade 2s, and yeah, I would agree with that. And here, this in contrast, you can see is pretty different. There's no cartilaginous differentiation here as well. And already on the chat, I can see people are providing a diagnosis of dedifferentiated chondrosarcoma. And sure enough, this is a classic dedifferentiated chondrosarcomas. For the younger trainees online, this is a classic example of dedifferentiated chondrosarcoma with sort of low to intermediate, well-differentiated chondrosarcoma with this abrupt transition. Notice the abrupt transition into a dedifferentiated component. In this case, it's all spindled, fascicular, and high grade as well, and a lot of mitoses. So high grade dedifferentiated chondrosarcoma would be the final diagnosis here. Historically, oh yeah, there's some necrosis here as well. Again, just to we didn't talk about necrosis in the uterus in the earlier slide, but remember that it's an abrupt change from viable tumor to necrosis. And this is a nice example of what I like to see in the uterus as well, this abrupt change without the hyalinizing stroma in between. And the differential, of course, would have been hyalinizing infarction, but this is abrupt, ugly cells, and then necrosis with nuclear detritus, debris, etc., etc. Okay. Somebody is asking me what type of dedifferentiated this is. That question is pertaining to does this dedifferentiated sarcoma here show any heterologous differentiation? That's what I'm assuming. So remember that dedifferentiation can transform into osteosarcoma, into myoid sarcoma, showing muscle differentiation. So I'll be honest, I do not typically investigate that. I know there were papers from the Memorial Sloan Kettering saying that there is a different prognosis in those that show bone differentiation or myoid differentiation. As a rule, our oncologists treat them the same and do not ask for the differentiation. So I did not do that to answer your question. Yeah, there is somebody's answer. Does identifying DDIF really matter in management? And it's more in the prognosis, according to MSK. There was a paper about 4 or 5 years ago, I think, either Modern Pathology. I think it was Modern Pathology that speaks to the heterologous differentiation and dedifferentiation having a poorer prognosis in certain subset. But I don't work it up. So how to work up DDIF is only samplers. Yeah, well, that is a great question, isn't it? How do you work up a DDIF? If the needle went through here, then you would have a problem, wouldn't you? Because you would not have seen the cartilaginous component. Your needle would be showing you a high-grade sarcoma, and you would be investigating for a high-grade sarcoma. So that's an excellent question. But you have radiology, which is going to be helpful because that would show the residual well-differentiated and then the dedifferentiated if you're lucky, because the dedifferentiated can override all of the well-diff, and you may not see that on radiology, and you may only see it on microscopy with little residual islands. Again, you might get rhabdomyoblastic differentiation and consider intraosseous rhabdomyosarcomas. You may get bone differentiation and consider whether this is in fact a osteosarcoma. Again, you're going to go back to radiology and you're going to go back to your clinical. Remember, osteosarcoma has a particular age range. It has a biphasic age distribution. So you're going to apply that. Is this an osteosarcoma? We confine ourselves to intraosseous tumors. We're not talking about the surface ones. I know periosteochondra was mentioned there, but we confine ourselves to the medullary tumors, intraosseous in this respect. There's somebody has put, thank you, Tom, my colleague, Dr. Hu, has posted that paper that we were talking about, and that's very useful. Shaheen, core biopsy, can we sign out as chondroid neoplasm when dealing with DDIF of? Yeah, again, that's a great question, Shaheen, because your needle core may show very well low-grade chondroid neoplasm. You're going to depend on your radiology to distinguish that. And if you don't have radiology, that is what you're going to call it. I would use the term low-grade chondroid neoplasm or well-differentiated cartilaginous neoplasm, or sometimes I would use the word atypical cartilaginous neoplasm. Now, remember that the WHO recognizes well-diff as atypical. This is taken from the atypical lipomatous tumor. It's the same story there as well. So it depends on the degree of atypia that I see, that I feel that this may be favoring more sarcoma, then I would use atypical chondroid neoplasm. But if I don't, and if it's very well differentiated, and I do not have my radiology, and I cannot tell whether this is a benign radiology or an aggressive radiology, then I would use the term well-differentiated cartilaginous neoplasm, C note, defer to radiology for further characterization. So that's an important component. Does SATB2 expression No, well, you can get SAPB2 expression in any cell that has switched on its genes to produce bone. So it's not specific at all. Even in a sarcomatoid carcinoma of the upper aerodigestive tract, if that is showing osteosarcomatous differentiation, it's going to be SAT2 positive, but it's not going to make it an osteosarcoma. So even without, yeah, you can get that. I've seen that SAPB2 immunoreactivity without osteoid as well. But again, my interpretation of SAPB2 and my interpretation of when do I use osteosarcoma is based largely on the clinical and the radiology. That is critical for me before I use it, because remember, if you're getting heterologous differentiation in an odd site, we may or may not have talked about this previously, but always ask yourself, and particularly in needle core biopsies, if you're getting bone in an odd site, if you're getting muscle in a very odd site as well, always ask yourself, is this one of the tumors that shows heterologous differentiation, i.e. like sarcomatoid carcinoma? So if you're in the head and neck and the aerodigestive tract, you're going to make sure you rule out sarcomatoid carcinoma before you make a diagnosis of sarcoma. And that's important because the treatment is entirely different. Remember, it's not only carcinomas that give you heterologous differentiation. Here we're looking at a D-diff sarcoma that give you heterologous D-differentiation. Also, melanomas can give you D-differentiation, and people have used all sorts of names like trans differentiation, etc., etc. But you have to keep all of these in mind and use the appropriate immunos, and importantly, go and look at your clinical. Melanomas occur years and years ago, and you have to go and look at your clinical. And if you have access to EMR in your hospital, then spend some time looking for that before you make a diagnosis of sarcoma in an odd site. And I took the example of head and neck because you need to be very cautious that it is not a sarcomatoid carcinoma, whether it's in the larynx or even the oral cavity. Be very, very careful of making a diagnosis of sarcoma. There's another question here. What do the basic immunopanel need to confirm sarcomatoid carcinoma? That's an excellent question. It's an excellent question. And again, if I suspect, if it's an, let's take an example. If this is an oral cavity biopsy and it looks sarcomatoid, okay, spindle, giant cells, necrosis, atypia, then my reaction to that is I'm going to use all the keratins that I have in our laboratory to rule out sarcomatoid carcinoma. And I really do that because I start off with a A1, A3, and pan-CK. Pan-CK, both these have different cocktails. And if you have both, then that's useful to you. I think it's about 5 or 6 keratins in each of those. So I would use both those. I would use CK56, which is a high molecular weight keratin. It's also used, just to remind you, bring some relevance to it, mesothelioma and squamous cell carcinoma. And then I would also use 34 beta A12. In our lab, it's called CK903, and that's a high molecular weight. There's about 4 keratin molecules in there that belong to the high molecular weight. And I'm emphasizing the high molecular weight keratins because those are the ones that pick up the sarcomatoid carcinomas. P63, don't forget, nice nuclear marker, and P40 even more specific, but you hardly ever see that. But if if your tumor is expressing it, it's very useful. How many have I given you? I don't know, 5 or 6. And then CAM 5.2 to balance the high molecular weight, because CAM 5.2 is a low molecular weight. Keratin has 2. I think it's 5 and 18. Both those are low molecular weight. And so that's the panel that I would use for working up a sarcomatoid carcinoma. So I use every marker that I have before embarking on other groups of tumors like melanoma or sarcoma. Okay, and of course, clinical and radiology. I cannot emphasize that that is critical to you making a diagnosis. It's never about just the needle core biopsy. You have to look at the radiology. You have to look at the clinical. I'm not even talking about bone now. I'm talking about head and neck, a sarcomatoid carcinoma. You have to see what you're looking at. What is the clinician thinking? What is the surgeon thinking? And what do they see in the OR as well? So all of that is exceptionally, extremely helpful in these difficult needle core biopsies. And I emphasize that in needle core biopsies because you're just getting a little window into a large tumor. And so you want to use all the means that you have at your disposal to arrive at a most accurate diagnosis that you can come up with. All right, I've deviated and gone way off, but a nice example of a D. diff a chondrosarcoma. For those of you who like history, this was the original tumor. I'm just blanking on. I'm thinking of Dr. Dalen, Dr. Dalen. I think, yeah. He's the original bone pathologist, Darlene, Dahlin, Darlene, from the Mayo, who described this in the 50s. And D. diff chondrosarcoma was the first prototype of the concept of dedifferentiation. And that's why the definition has stood the test of time. It's got to be an abrupt change from a low grade to a high undifferentiated component. Now, you all know we apply this in liposarcoma as well. So we have a dedifferentiated liposarcoma, same concepts and the same principles that we used, 70 years ago. And I could go on. There's D-diff SFT. There was a nice paper, I think, in last month's AJSP from the late Dr. Fletcher's group, D-diff SFT, solitary fibrous tumor. And there's D-diff leiomyosarcoma, and a whole slew of those people have used them. Even the head and neck people, salivary gland, adopted at one point, but they've rapidly dropped that. And now we talk about transformation of carcinomas in the head and neck. And so historically, this was the tumor that gave the terminology of a D-diff dedifferentiation. All right. I don't see any more questions, so I think we can. Let's see. I'm gonna move to another. I think we've finished this. Just gonna move to another group of. What number was that? Sorry, 21. I couldn't find 22 for some reason. I'm gonna ask Tom to come and help me find 22 when he comes on. I'm gonna go jump to 23. And this is just my poor organizational skills. 22, 23. No, I don't even have my histories out for 23. My bad. Let me just jump to one that I do have some histories out. 25. Okay, there we go. I found one that I do have some history here. 1060 OR 1060. Yeah, there we go. So let's just move this across, get the chat to one side, and let's get back to some good old surgical pathology. This is a 19-year-old woman, and this was a vaginal mass. This was also a consult from the outside. So it was grossed in the outside. And so I'm going to show you. Okay, here you can see. So it's a vaginal mass. It's a squamous line mucosa and looks a little hyperplastic, but no ATIP. Yeah, I'm not going to go into dysplasias here unless somebody asked some questions, which I don't have any examples to show you any dysplasia, but here we go. So submucosa, and there's this well-differentiated tumor. Looks pale. Just going to take you through a low power view of it. We just have a wedge of it. Oh, look, there's some microcystic changes here. Nice microcystic changes, so I don't forget to come back to that there as well. Let's show you some cytomorphology. Okay, so it's sort of, they're loosely cohesed cells here. They seem to be linking up. I wouldn't say that they're independent. They seem to be linking up. I'm not going to describe stroma. I'm just showing you the cells. I don't want to mislead you. Here, less cellular, ovoid, spindled. Okay, and there seems to be an array. And again, I'm just describing as I see the arrangement around some of these vessels here. And here these microcystic areas, what looks like microcystic to me. You can see that they have this material in them. Here you go, sort of pools of this material. Oh, look, this is around a vessel as well. And again, that's not a diagnostic feature. I'm just pointing out features to you. Okay, so there's that microcystic area. There's this pale, is on a basic autoplan with 30. Oh, I don't know what that means. Edna Rossio. Sorry, I don't know what that means. I don't know, Ava, what those mean. Okay. Okay, any thoughts? So I've shown you the more cellular areas here, down here, these less cellular with microcystic changes. And she's 19 years old. I should remind you, I don't have a size, I'm afraid. I apologize. I don't have a size. It's a vaginal mass in a 19-year-old. And this is just a wedge. I couldn't give you a size. I apologize. Here we go. Just both the morphologies, cellular sheets of cells, microcystic changes, and then here, sort of loosely cohesed. I'll use that word, loosely cohesed. I'm going down on high power here now. Microcystic schwannoma. Okay, so we got some suggestions. I love this. I love this. So thank you, Dr. Jayanthi. S100 SOX10 will quite easily take care of that. So no, it's not a schwannoma, and I did do the my screening immunos we talked about my panels earlier on. My screening immuno for schwannoma is S100 and SOX10, which covers melanoma as well. There is an angiomyofibroblastoma. I think there's a fibro missing there. Angiomyofibroblastoma. Those are typically well circumscribed. And I know why now. I know why you put that in. That's a very good thought, because of that arrangement around the vessels. They're more epithelioid cells in angiomyofibroblastoma, and they're Desmond positive. This was Desmond negative. There was no Desmond in this, so I did do Desmond as well. But Desmond is negative. Those are also CD34 positive, are they? I think they are. Subset of them are CD34, so it's not that. But yes, I did think of the lower. I call these the lower genital tract mesenchymal tumors, and that's one of my differentials in that, including cellular angiofibroma and myofibroblastoma. All right, endodermal sinus tumor, yolk sac tumor. Yeah, that's been in the literature recently, particularly the vulval ones with these nondescript tumors showing yolk sac differentiation. So here the question is this a yolk sac germ cell tumor? How many, Azad? I'll be honest, I did not do the germ cell markers. Yolk sac is a good thought. No mitoses, a few scattered mitoses, no atypia, no necrosis. So, yolk sac tumor did not come to mind. But again, I think you're thinking of that because of the arrangement around the vessels, the so-called, Schiller-Duval bodies. Yeah. Could these be Schiller-Duval? That's a good thought. And that's the reason I love your differentials, because I actually, my brain's one track because I've worked this up and I've got the immuno out. So I'm not thinking of the differential. Pleomorphic adenoma-like tumor. Oh, I love that. Olga, that's I don't know if that's a diagnosis in the general tract, but it's interesting. Pleomorphic adenoma-like. Oh, here's an interesting one here. Aggressive angiomyxoma. So that's a very good one, Dina, because this does look myxoid, and I did not want to use that word myxoid I wanted you to pick up the myxomatous stroma, and it is myxoid. Aggressive angiomyxoma, again, you got to go back to your clinical, because when your GYN oncologist biopsy that, they will tell you this is deeply infiltrative of the pelvis, and that is key to your diagnosis. 1. 2, this is too cellular for an aggressive angiomyxoma. Remember, the WHO, by the way, calls it deep angiomyxoma because they're not as aggressive as was initially thought. So they call them deep angiomyxomas, and they're not as cellular. Open the WHO, look at the pictures, you'll see they sparsely cellular, hypocellular, if I can use that word, and you may occasionally get some strands of smooth muscle across it. If you have HMGA2, that's useful for that as well, but otherwise a clinical pathological diagnosis, deeply infiltrative would suffice to make that diagnosis. Low-grade fibromyxoid stroma. I think you meant sarcoma, I would imagine. Okay, low-grade fibromyxoid sarcoma. Again, the cellularity is a little too much for that, but it does have the myxoid stroma. Remember that the low-grade fibromyxoid sarcoma typically has these alternating areas. They vaguely lobulated of hypocellular with mildly cellular, and that's the key here. Here we don't have alternating. I guess you could argue these microcystic areas look different from these areas where it's more sheet-like. You could argue that, but it's an easy deal, right? All you need is MUC4. If you have MUC4, that's very useful to rule that out as well. By the way, anything that has myxoid and stroma, as my own approach, I always do a MUC4. So in truth, even though what I was saying to you, I probably did do a MUC4. I cannot remember, but my general approach, if there's myxoid material, I just do a MUC4. I'm talking about biopsies, obviously biopsies, but in this one, okay, so there's aggressive, and you're getting that again. I'm going right down to the bottom. Solomon, right. I hope you don't mind me mentioning your names. It's lovely to mention your names because I see it here. Low-grade fibromyxoid sarcoma, we just talk about that. Little two-cellular MUC4, sort that out. Alternating hypocellular areas. Benign mixed adnexal tumor. That's very interesting, Solomon. There are no adnexal structures in the, maybe there are, but benign mixed tumor is interesting. Quadriceps, nice. Angiomyofibroblastomoma, that's what we talked about earlier. And those are Desmond positive, CD34 positive. Chondroid syringoma, I like this. So I've got chondroid syringoma, benign mixed tumor. And then there was one up here. Oh, there's a new one I missed here. I beg your pardon. There's a couple I missed. This thing is moving too fast for my eyes. There was one here with that said, there we go, pleomorphic adenoma-like tumor. Okay, all three, just keep those in mind. Exoskeletal myxoid chondrosarcoma. Again, this is a little too cellular, but remember the high-grade ones can be cellular. Remember those have a fusion as well involving NR483 and EWSR1. If you have that, it's useful to work those through. The high-grade ones have neuroendocrine and INSM1 differentiating, but otherwise there's no immunos to make a diagnosis of exoskeletal myxoid chondrosarcoma. In the old days, they said S100, 20%. Nowadays, that's in a little bit of a doubt, but it's an important differential diagnosis for this tumor. Myxofibrosarcoma. Okay, those have to have atypia. She's a little too young for that, even though there was a paper from, I think, the Mayo, I want to say, Modern Pathology, a couple of years ago, maybe last year, describing myxofibrosarcomas in younger patients, by younger meaning less than 40. If osteoid present, thinking of OFMT. There was no osteoid in this one. But remember, you can also get a non-osteoid or non-ossifying fibromyxoid tumor. Again, CD34, some Desmond. And if you can get your hands on fish, that's useful as well, with PHL coming up. A small subset as TFE3. Now, I'm going to go back to those three differentials. End-track rearranged sarcoma. I'm glad you mentioned that. Those are pretty spindled, uniform, some myxoid stroma, a CD34 positive, and S100 positive in a patchy distribution. And again, you're going to have the antibody to make that diagnosis to end-track 1, 2, and 3, or if you've got FISH or access to next-gen sequencing. Epithelioid sarcoma. Okay. Mukuka. That's a very good thought. We've seen a handful of these occur in the proximal variant of epithelioid sarcomas in the vulva and GYN tract. This was CD34 negative to start off with, but it was also keratin positive. So I'm giving you that because you mentioned epithelioid sarcoma. It was keratin positive. It was also ER positive and did show some focal calponin positivity. Okay, so I've got ER, not surprising, we're in the mesenchymal genital tract, and ER-PR, but the keratin immunoreactivity as well as the calponin. And now you know why I was referring to those mixed tumor and pleomorphic adenoma-like, and even a chondroid syringoma. Those are correct. Those are exactly in the same ballpark of what this is. Now, in the old days, when I was your guys' age, this used to be called a spindle cell epithelioma, a vaginal spindle cell epithelioma. You can even get some squamous differentiation in it. But recently, in the last, I want to say 5 years or maybe a little longer, Dr. McCluggage, you know, the famous GYN pathologist in Northern Ireland, Belfast, he wrote a nice paper saying these are in fact of myoepithelial origin, myoepithelial-like. So all of those terminologies are in that ballpark, and he used the term, vaginal myoepithelial-like or myoepithelial-like tumor. But the old name was spindle cell epithelioma. You can go to the old books if you have the armed forces, which I still have here on my shelf. Yeah, myopithelioma. Somebody has given us myopithelioma. So that benign mixed tumor, that was the other name for a spindle cell epithelioma. And those are all correct. So those are all in the ballpark of with myopithelial differentiation. And because it shows keratin and shows some muscle immunoreactivity. Unfortunately, the S100 was negative, and I remember that coming up earlier on with the suggestion of a schwannoma, microcystic schwannoma. It would have been nice if we had some S100 as well, but that was negative. Trying to look for inflammatory infiltrates, consider IMT. Yeah, that's a good thought, Solomon. Myofibroblastoma, we've had that. I think I've covered metastatic breast carcinoma. Well, again, she's 19. So spindle cell, there we go. There we go. Somebody is thinking of that as well. Epithelial, myopithelial carcinoma. Dina, these can occur in the vulva, and I have seen them. If you go to WHO, there's a small subsection of these tumors that occur in the vulvovagina area, the so-called salivary gland-like tumors, and epithelial myopithelial carcinoma has been described. Remember, that has a very distinct relationship between the epithelial cells and the myopithelial cells. And they can form tubules, they can form trabecular, they can be basaloid, they can be cribriform, etc., etc. But if you cannot see that relationship between the epithelial and myopithelial, you may have to resort to myopithelial markers. P63 is a good one, P40, or even the muscle S100, SMA, that sort of a thing. So you can show a nice relationship between that. But this was well circumscribed, not invasive, benign, entirely benign. And that's what I called it, a myopithelial tumor. Yeah, I use that term here. Let's see who put that in the myopithelial tumor. Abdullah, correct. And Dr. McCluggage brought that term. And I think the new WHO or the next iteration of the WHO probably show that if it's not already in the present one. So good differentials, guys. I'm really enjoying looking at your differentials and putting them on the chat. I don't see any more questions or comments. I think we probably can squeeze in one more. And it's a neat case. Let me see if I can find it for you. I was on my way home one day last year when my friendly hematopathologist from CHOP is Children's Hospital. He texts me. He texts me with photographs, and I get a lot of text photographs on WhatsApp as well. But this was on text, 1802, and he says, "What do you think of these?" And I was minding my own business, going home. Now, if I could find it for you, that would be nice, wouldn't it? I think it's this one here. Oh no! Oh, there we go. Sorry, my bad. Yeah. Unfortunately, I have to manage all of this myself. Ava. It'd be nice if all right, doesn't matter. So how about this? So he texts me these pictures. It gives me a history, and he says these are neck lymph nodes. There we go. Here's some lymph node tissue. I think. No, not. All right. So he texted me. He actually texted me the blood smear. This may have scanned a little pale. I apologize. This is the high power. You can see plasma cells and lymphocytes and some tingible body macrophages. Feel free to let me know what you think. And I'm going to show you different areas as I scroll around. So neck mass. I don't have an age for you. Neck lymph node. That's all I have. And this came from my colleague, Dr. Vinod Pillai. Okay, we are sailing here. All right. Okay, nice. We've got histoplasmosis and leishmaniasis. Uh, that's the differential diagnosis. That really is the differential diagnosis, histoplasmosis. Now, I deliberately moved away from those vacuolated cells because as I approached it, I realized this was too much of a giveaway, right? There you go. That was too much of a giveaway. So now you guys see much more. I used to see this in my younger days when I was in South Africa, and I don't see this much more. But this is exactly what I said to him. I said histoplasmosis, but don't forget leishmaniasis looks very similar, and they both stain up with the silver stain, and some of these you could probably see those little structures. Yeah, there's one here. You can probably see those little structures. It's getting a little blurred as I go higher power, but those little structures. Penicillin marfeni differential. Yeah, that goes above my pay grade, Venkatesh. The last penicillium I saw was in the liver that I thought was aspergillus. This was many years ago, and I called it aspergillus. And 2 weeks later, the clinician calls me and says the microbiology showed this to be penicillium. And that was the last time I ever tried to speciate organisms on H&E. Solomon agrees with both, and we need GIMSA and GMS. Now, what about the PAS-D? I think the PAS-D is positive in one, but negative in the other. I want to say you guys know this better, but PAS-D is also discriminatory. And this, in fact, is and was leishmaniasis and was confirmed with the microbiologist as well. So penicillium, forgive me, but can that be yeast form as well? I'm sure it can be yeast form. That's why you put it in the differential. The one I saw was branching filamentous hyphae, but here you go. Nice leishmaniasis. Just to sort of round off, we've got 5 or 6 minutes. I can take any questions if there's any questions on any of the things that we talked about, any of the immunos we talked about. Happy to address those with you. If not, just to mention that the next meeting, I'm just checking that out. The next meeting is going to be November 5. Same time, same place. Now remember, I think our times may change. So you guys in Africa or Europe, Middle East may have to adapt to that. So you may be 1 hour later. So if fall behind. I get confused, but remember there's going to be a time difference with you. So just check your time analysis, okay? Otherwise, yeah, it's a pleasure having you, and I'm also pleased to have spent the time. So we'll see you on November 5, and we'll continue with the same approach. Yep. Thank you, guys.